interviewer asked in modern healthcare, what are your top priorities right now with Ascension Health? And he responds, we're clearly continuing to move to fee for value, which means we have to continuously grow, cover lives, and focus on our capabilities for assuming risk. That's an area where we believe we're going to have to partner with somebody who really understands risk. Many of us tried it in the 90s when managed care was here, and many of us lost our shirts because we truly didn't understand risk. So I wanted to begin kind of this session with that quote to understand that we're going to focus on the 5 essential steps of ACO risk management. And then John Woods, I'm going to pass it on to John. John Woods will talk about how to move from track 1 ACO to the next generation ACO, which involves going from upside only to downside risk. And then Terry Cheshire is going to close us out with managing ACO through risk through reinsurance. So that's kind of what's coming up. And then Sam mentioned earlier that as you write your questions down, she'll present those for us at the Q&A section at the end. So Sam, if you're ready, we can go to the next slide. Okay, I'm going to move through these slides fairly quickly because we got started a little bit late and we're running short on time anyway. The only thing I'm going to say here is, as you can see, accountable care organizations are growing very rapidly. There's 13 times more ACOs in the last 5 years, and many, many more to come. Began with the pioneer ACOs and is climbing up to a combination of commercial and Medicare ACOs, kind of a split right now, 50-50 between those two. Next slide. So what's ahead for ACOs? One word, risk. There's no two ways about it that we're going to see more and more alternative payment models, or APMs, that, as it says in this quote, is exploding according to CMS. There's 4 different APM models ranging from different kinds of risk models, which John Woods is going to talk about, bundle payment models, etc. All of this APM acronym kind of got started with the introduction of the MACRA program last year. John's going to talk more about that later. But as you can see, 12.3 million Medicare and Medicaid beneficiaries already within these ACO and bundle payment models. John's going to talk about next generation ACOs where there's more risk and more reward, and CMS is pedal to the metal on these next generation ACOs. As you can see, they now have 45 in place and climbing quickly. Okay, next slide. So health plans have been a little hesitant to adopt risk-bearing contracts. But CMS, again, has kept the pressure on, and their expectation is to have somewhere between 25 to 75% in the next 6 years. So we're going to see a lot of activity on the ACO and on the ACO risk-bearing front. Next slide. This is the risk spectrum, if you will, that ACOs will move through, or providers will move through, going all the way from fee-for-service to shared savings arrangements. Shared savings, of course, at the moment are mostly upside only. When it gets to shared risk, you see my red dotted line there. I'll come to that in just a moment. But when they move to shared risk, then there's some downside risk involved. And when you move to capitation, you've got full downside risk for the total cost of care for a given population. Joint ventures is what Anthony Tersigni was talking about with Ascension Health. That's what they're looking at right now, of joining in a joint venture with a major insurer to introduce insured products in the marketplace. And eventually you could get into provider-sponsored plans only. That's when providers will introduce their own insurance plan into the market and compete with those insurers as well. Main point I want to make on this slide is, with the red dotted line, is that as you move along the risk continuum, the financial opportunity and incentives increase pretty dramatically when you move away from upside only to taking on risk. Okay, next slide. So these are the 5 risk components that health insurers use to manage downside risk. And I think it's important for the ACOs who are beginning to move into this area to understand that these are 5 essential steps. I'm going to give examples of these in the next few slides, but let me mention them right now. Risk identification involves identifying contractual risk. In most of the ACO contracts we see right now, those contractual risks, and I'll give you an example of it in just a sec, involve not meeting cost and quality benchmarks. Then there's risk avoidance. That's avoiding any downside risk at all. So this would come into play when physician members are risk adverse, and there are ways that I'll talk about in just a minute to move them away from just being adverse to acceptance. Then risk prevention is reducing the likelihood of losses. So this is preventing losses from occurring in the first place, and that includes limiting the frequency of unnecessary admissions and ER visits. Then risk reduction means these are losses that are going to happen, but you have an opportunity to lower the severity of those losses. And this is where it comes into play with case managers, care coordinators, tracking disease registries, and doing what I'm seeing a lot of the ACOs focus on right now, and that's care continuum transitions. It's becoming very important as the ACOs begin to understand that the bulk of the risk for an admission, for example, or for a case, comes post-admission. So that care continuum is becoming increasingly more important. And then the 5th one is risk transfer, and that's where you have appropriate reinsurance. That's what insurers do, is they lay off a lot of that risk and they spread it all the way through worldwide risk reinsurance networks, and it's generally in the form of specific and aggregate stop losses. And Terry will talk more about that in a minute. Okay, let's just take a look at a couple of examples before I turn it over to John Woods. This is an example of a cost and quality risk identification, cost and quality benchmarks. These 2 slides that I'm going to show you right now, and again, I'll move through them fairly quickly, but these 2 slides are actual excerpt from a contract that we just presented to one of our clients recently, showing what happens if you go 5% below the target or 5% above the target as far as cost is concerned. And that means if, again, you look at line 3, then in this example, the cost target is $298.09. If you hit below, 5% below that, it comes to $283, and you get compensated, as you'll see in a moment, for that return. If it comes in, the cost comes in 5% above at $313, again, that 5% is going to be a loss instead of a gain. So can you still hear me, Sam?
Yes,
Sam?
John.
Okay, we're good. Okay. So again, if you look at these next 4 slots, talk about minimum savings percentages, minimum loss percentages, maximum saving, maximum loss percentages. These are all part of the contract, and that asterisk means that they're negotiable in part, and that's one of the things you want to look for as you enter these agreements. The accountable care payment is an advance payment that we've seen range between anything from 50 cents to $3. Typically, in this example, it was $1.50. And that means that that money is paid in advance on a PM basis to the ACO to help offset its additional care coordination costs. But as you'll see in a moment, it also gets recouped in the form of a payback from the shared savings. Those dollar amounts you see with minimum savings, minimum loss, max savings, max loss, those are just the 15% converted into dollar figures. Okay, next slide. We're coming up on the end of this example, but here's where it gets very important. So the share amount that you came from the previous slide, $14.90. Line 16 says that the insurer is only going to be concerned with their liability, which in this example, the actuary department estimated that it would only be 80%. That other 20% will come from the patients or the members. So that leaves the adjusted incentive share 80% less, which means it's $11.92. So here you have under these contracts 50-50 split and a quality adjustment percentage under the scenario here that says, okay, you didn't quite hit all the quality targets, so we've adjusted it down to 47.5%. You're going to lose some of that from your only reaching 95%. So your savings share is only going to be 47.5 instead of 50%. Now you'll notice that they don't adjust the quality adjustment on line 21 because that would result in them actually rewarding reducing the liability because it didn't meet the quality targets. In any event, line 22 is the total group member months. That's 10,000 members times 12 months, leading to an earned incentive total of $679,651, or a loss under scenario 2 where you went 5% above the cost target of $715,423. In either event, you got to pay back the advance payment of $1.50 times 10,000 or $180,000, leaving you with either a return of nearly $500,000 under this example, or a liability of nearly $900,000. That $900,895,423. It creates the opportunity for reinsurance that Terry's going to talk about when he gets to his section. Okay, next slide. So step 2, risk avoidance, and I know I've got to keep moving through this fairly quickly. It comes into play where you have the risk of adverse risk for physicians who are members of the ACO. How do you change that? Well, what we found is there's a need for a physician culture change to change their engagement and their commitment. How do you do that? Well, you get their representation and their engagement more right at the top of the organizational chart, from governance to board of directors. You try to get them involved in medical committees. You try to establish regional CMOs if you break that into different regions geographically, and you try to get them to attend meetings and conference calls. Some of the contracts we have seen presented or been involved in require a mandatory percentage of physicians to attend operational meetings, like 75%, etc. And then on a commitment basis, how do you effect that cultural change? Well, you have to move from risk adverse to risk readiness, and incentive compensation is a good tool to accomplish that. So if you think about all of your physician members in an ACO along a bell curve, that's what this shows here. It shows that on a risk readiness basis, you're going to have champions, you're going to have folks that are physicians that are positive, some that are kind of leaning negative, and some that are won't enter these risk agreements at all. And so your goal as you go through these culture change endeavors is to try to skew this to the left, try to move more and more of your physicians to a positive risk readiness status. Okay, next slide. These next 2 slides have to do with risk prevention examples. There's a lot of, you can see busyness here, but I wanted to give you examples specifically that came from a action plan of a ACO to reduce risk prevention, and that's meaning reducing the likelihood of losses coming about. And that would be things like reducing the likelihood of admissions and ER visits, etc. So this is a real live action plan, and I won't have time to go through all of these, but again, I wanted to give you at least 4 examples here. So one of them on a project basis is emergency department narcotic driven patients, and as you can see, they're talking about repeat patients in the emergency department that are coming in with unmanaged chronic pain or narcotic abuse, and so they're crafting a program to identify and assess those patients and no longer dispense narcotics in the emergency department. Where you look at the population as you complete this action plan, kind of estimate specific to your ACO, what's the population of patients likely in this category, and that population then will give you the estimate of what the preliminary savings would be. In this example, you can see it's $1 million to $1.5 million is their guess. Key elements, that means what are we going to do with putting together this risk prevention program for ED narcotics? Well, it requires, of course, identifying the patients, flagging the patients for the MD, and then the physician discusses, in this example, with the patient the situation and has the patient actually sign a contract, and through that contract, they navigate or direct them towards pain or spine for primary care purposes. And they then subsequently flag the patients as having a contract or not, and then those who do, they no longer administer those kinds of narcotics in the emergency department. There are risks and barriers. I won't go into all of those, but you get the idea that this is an action plan that is getting down into the weeds that you have to get to in order to really start making a difference in reducing the risk and the likelihood of losses. Okay, let's go to the next slide. So in addition to the one centralized transfer center, here you have specialist accountability, how to deal with specially on-call service agreements for specialists, and then another intriguing one with emergency department abusers. This time you take more aggressive action towards the emergency department abusers who are non-compliant after care management consultation. And if you look over to key elements and then you go down to that third bullet, it can get as intense and as aggressive as notifying the member and the hospital's emergency department visits will no longer be covered for non-emergent care, and no claims will be paid. This requires cooperation from the insurer, and that's why there is collaboration that is important as you begin to take on risk. Okay, next slide. Step 4 involves lowering the severity of losses, risk reduction. So this means you're going to incur losses, but how do you manage those losses that you're going to incur? What you're looking at here is something we developed in upstate New York as a, I guess you'd call it a population health management grid. And the focus, as we found out, is on provider communication. That's what those little arrows are circulating back and forth in between the internal care team, which is led by the primary care physician, and the external care team, which includes specialists, emergency room, hospitalists, social workers, etc. And you can see that that external care team changes, as does the internal care team a little bit, changes as you have different patients, as you've sorted them into these 4 classifications of population: healthy patients, patients with an acute condition that once treated, they'll become healthy again; chronic patients, normally those with comorbid conditions that aren't going to get healthy again, but that needs to be managed effectively; and then end-of-life patients that need palliative care. So putting together something like this, communicating it, getting all of the providers engaged on the external and internal care team means those are the folks that belong to the ACO. They actually are part of it. The external care team are more likely contracting providers and communicating through using things like the EMR, meeting over quality data reports, all the other kind of stuff that's presented here is the best way to manage the severity of these losses. Okay. Step 5 is risk transfer example. This is what Terry Cheshire is going to cover as he closes out his session. But basically, it just says that the ACO can transfer some of this risk, he'll explain how, over to a reinsurer. And the way that that will work is there are specific claim limits, there's aggregate claim limits, and then there's things like benchmark reinsurance. So I just wanted to close this out by just saying all of these steps are steps, again, that insurers take that ACOs are going to have to become proficient in order to manage downside risk. Okay, next slide. Okay, I'm going to turn it over to John Woods at this time to talk a little bit about an example of moving from track 1 to next generation. John's had experience in this and running his own multi-state ACO. So, John, you want to take it from here?
Sure. Thank you, John, very much. As you can see, when you move from no risk to and just upside programs, the government is doing everything it can to really encourage us to go ahead and take the downside. In my particular example, we've made shared savings every year since 2012. Our physicians are very good at tracking the quality measures. We've learned how to do our reporting. So our ACO is ready to make the step. Now I'm in the second year of my 3-year contract, and CMS has said basically now I'm going to have to refile. So I have approximately 13,000 patients in the ACO right now, and I'm evaluating the number of physicians that I think are ready for either the Track 1 Plus or the next gen. And to go over the differences here, the next gen allows for 80% of the up and down side against your benchmark to a maximum of 15%. You have to post 2% of your money as reserves. You have to file a letter of intent by May 4th. You have to file your application by May 18th, and you have to pretty much have your physician network in place by the middle part of June in order to create this next-gen ACO. And then we give you some examples of that your downside's actually a little bit more, because your benchmark will be reduced by 2.25% when you move from the next gen to, I'm sorry, from the Track 1 to the next gen. And right now these numbers are based on the 2014 experience that your ACO has. Next slide, please. So within this program, they give you several tools that I think are very helpful. And one, of course, is the ability to waive the 3-day admission to a skilled nursing facility. In our experience, maybe as much as 25% of our hospital admissions that are low acuity could be admitted to a nursing home if we had the right nurses, if we had the specialists that were willing to follow them. And that's where telemedicine comes in, trying to get your best specialists to follow the patients at these lower level services. And again, everyone's aware of the postings that you have to do with CMS, but the language is very uncertain as it relates to how you're going to work with the states. And most of these states, I think, eventually will get around to making you post reserve money. The difference between the Track 1 Plus and the next gen is that you're limited to 4% of the downside. So the next gen lets you participate up and down to a maximum of 15%, and the 1 Plus reduces that amount of your risk exposure. Next slide. One of the other advantages of the risk-bearing ACOs are that you qualify as an alternative payment model. And in these examples, any bonuses that the doctors earn accrue to the ACO. So in the past, we reported the PQRS, we were graded on our meaningful use, and those items now are rolled up under MACRA. And MACRA has 2 components. Again, the MIPS programs for the doctors that are not included in the APMs. And then the, again, the next generation, or the 1 Plus, which take downside, which satisfy basically the physician's risk. And then we do the reporting under the MIPS to the government. So again, the differences between the Track 1 is that you have 30% downside to a maximum of 4% of the benchmark, and you get 50% of the savings. The next gen, 80 to 100% of the up and downside to a maximum of 15% of the benchmark. So when you're choosing these models, you need to be very careful about, again, your risk tolerance in these examples. Next slide, please. Expansion of services to include the ALFs and the skilled nursing facilities. If you think about it, your physicians care for patients in these facilities, and your risk is really a lot higher with these patients, and your benchmark is adjusted based on the censuses that you have. And if you're working more in these sites, the case mix for these facilities is going to increase. So I see a lot of opportunity for ACOs converting to next-gen to include the ALFs and the skilled facilities in your physician networks, and then use those facilities for these costs in order to shift care to a good level of care where the quality can be maintained, but at a lesser cost. And again, focusing on the waiver of the 3-day Medicare admission, it gives you an opportunity to improve the savings that you can generate under these models. Next slide, please. Here's a detailed financial analysis, and what I did in the first column is include how traditional fee-for-service Medicare would look in a budget with 5,000 patients. And then next to it, put my own experiences in terms of track 1 ACO, and then create a pro forma for what I think that the next gen may be able to do within my own program. So I'm highlighting the fact that under traditional Medicare, there's very little telemedicine with the primary care, and that what my physicians tell me is that maybe as much as 50% of the care that the patients get at the primary care level really don't require the patient to be face-to-face with the doctor. That as our systems and data have evolved, the doctors can, primary care specialists can use the data systems that we have to try to, again, fill in the care gaps and provide higher levels of care. The reporting structures still does not give you value for those telemedicine quality measures. You still have to do those face-to-face encounters. And on the specialty side, just highlighting again that a lot of services in the nursing home, for example, a pulmonologist, a cardiologist, a neurologist, could be provided to those patients that are borderline or maybe declining and avoid that inpatient stay. Next slide, please. And then again, just to show you the shared savings side of this, again, is I think the upside potential is as much as $125 PMPM. I've been doing Medicare Advantage for a long time. A lot of people quit doing the risk-taking after the 90s, but I never did. So a lot of my doctors are already involved in Medicare Advantage programs where we have downside risk and we buy reinsurance. And most of the commercial programs that my physicians are involved in are still only upside savings, shared, where they split the savings much like our track 1. But I would expect these programs to evolve just like Medicare is, and that those commercial programs are going to want us to be more risk takers as ACOs on the commercial side as this goes forward. Next slide. Terry, with that, I'll turn it over to you.
Thanks very much, John, and glad to be with everyone this afternoon. So what you've heard from John Schmitt is an overview of risk and how risk is increasing and how it's at everyone's doorstep. And then what you might do internally to respond to that risk as it increases. John Woods just gave a case study that risk doesn't have to be a 4-letter word. Risk can be a 6-letter word called reward. And you can turn it into a reward through reinsurance. So reinsurance is what one insurance company buys in the marketplace in order to protect its assets, earnings, and future profits. Next. So ACO today, many people say that today's ACOs will be tomorrow's health plans. So as John Schmitt said, if you're going to act like a health plan, the question begs, what do you need to do to assure profits? Well, you've got to mitigate that downside risk as you go through the various tracks that John so clearly outlined, be it track 1+ or 3 or next gen, with the various swings in potential profits. But you try to protect the large medical losses, and this is from reinsurance, and it's excess of loss for both ACOs, MSOs, or capitated providers. To claim in specific and aggregate, you see various policy limits that's provided, as well as deductibles that you can so choose to take. And then, of course, there's aggregate benchmark insurance that's available in the marketplace as well. Next. So, if you were to choose to have reinsurance, it really acts like a shelter or shield to do a couple of key things. Number one, you're going to better protect your profits. It converts the high risk into a more manageable low risk. And then you have control over it because now you buy it. And then you increase the profits through the reinsurance premiums that you have. And then there's another thing, and there's a lot of smart people in the world, but there's tax advantages if you create your own ACO-owned captive, so you become the bank. Most people don't realize this, but for de minimis money, you can be your own, quote, captive company for greater profits. Next. So here's a simple slide that we tried to show for FLACO. And if you look in the green, this is what the reinsurer pays, and this is the transfer that John Schmitt was talking about. So the blue, and again, your hand's on the buzzer, you can assume a $50, $75, or $100,000 deductible. After a $50,000 deductible, any claim above that or greater than that goes over to the reinsurer. So it's transferred. So down at the bottom, you see that with reinsurance, the funds can be protected, and there's zero risk or less risk. And then with the captive, the axiom says if you put money into the captive and then you pay losses, whatever is left over is not taxable. So that's the axiom. And that gives you the profits that you see under the ACO and so forth. Next. So what we tried to do in this particular slide is many of us live in Florida. We understand the hurricanes and the windstorm, and we know that if there's a hurricane, you can prepare. So same thing with an ACO. You can prepare for the coming event, and there's two extremes to this slide example. One on the left is the frequent low claims, and think of this as a car, okay? So you put gas in your car every week, $20, $30, $40. That's a known budgetable cost that you generally are going to spend week in and week out. On the other extreme is when you get in a wreck, you have insurance to pay for that car and repair the car. Same way with reinsurance. If you get a large claim above 50, 75, or 100,000, the reinsurer steps in and makes reimbursement back to you. What you're left with is those variable and manageable claims in the middle. And so the 65% moves over vis-a-vis the red line to the 65% budget. And this is kind of like your maintenance cost. This is what can be variable. The better you manage it, the more money you make. In this example, we've used 45% from the 65% equals 20% in profit. The question becomes, what happens to that profit? With a captive, there's no taxes, hence you have a net profit of 20%. Without the captive, the ACO profit is 20, but the taxman cometh at 40%, and you give 8% to the government. Fortunately, you're not in California, where it's like an additional 15% or 13% for state taxes. Leaves you net profit of 12%. Stark contrast between the two. Next. So to go ahead, John, you want to say something?
Yeah. Let me take this slide if I could.
Sure.
Because I think that's a great summary on the reinsurance side. So as we kind of close this session out, we wanted to talk about the 3 steps of how to transition into risk. So if you think about it, this is kind of, as we close it out, like I said, this is kind of a call to action. So you might be sitting there at that point and say, how do I get started in all of this? And it sounds like it's something I ought to do. What we would suggest you do is take step 1, which is a risk readiness assessment. And the 3 of us have spent some time putting together a risk assessment tool, which is free upon request. You can just send me an email. My email's on the last slide here. And take that risk assessment tool and start doing an internal assessment. Then, as you see that, you'll see what the gaps are between what where you're at right now and where you kind of need to get to and what needs to be done. Then the step 2 gets a little more complicated at that point, because now you get into the risk prevention, risk reduction plans that we talked about, and those require the kinds of detailed action plans I gave you examples of on those two pages. So it's a matter of getting involved, assessing that risk, then developing an action plan, and now once you've got that plan, now you're in a position to begin risk transition. So determine the risk acceptance. Remember the bell curve that we have for provider that we talked about. Think about implementation timelines. In other words, how quickly you can or should move towards this risk assumption, move towards a track 1+, or eventually a next gen, convert that into a game plan. And as you take that, then think about what are the 5 essential risk management steps that we need to take in the context of our own action plan. So there's a little bit of homework and work that needs to be done. Obviously, we'll help you if you'd like, but this is something that, again, if you're going to move along the risk continuum and get ready to get started, this is what we would suggest. And then finally, you're going to need to execute that action plan. So I think those are the 3 steps that we would suggest to begin transitioning from no risk to downside risk, using hopefully the slides we gave you earlier as a background. And again, I'd suggest that you take step 1 seriously, request a risk assessment tool to get started. So Sam, I think that concludes everything that we were going to try to present here, and I'll turn it over to you for the Q&A session.
Okay, perfect. I noticed that nobody had actually written any questions down. I will be glad to unmute those if you would like to raise your hand and let me know. If not, if there's anything else that John Woods, John Schmitt, or Terry Chesser would like to add to this. I don't see any questions. Hold on one second. I do have one that says, will we share the presentation? And yes, what I will do is I will actually post this to the FLACOS website later on this afternoon or tomorrow morning, so you will have accessibility to this, along with the presentation will also be posted onto the website. Any other questions? John Woods, John Schmitt, Terry Chesser, would any of you like to add anything else to this?
And instead wind up, you know, trying to get involved in getting started at least on a risk management pathway, and this is our best suggestion for doing that.
Perfect. Thanks. Then I would just like to conclude and personally thank John Schmitt, John Woods, and Terry Chesser for taking the time out of their busy schedule to present us with a wonderful webinar. Again, I will get this posted out by the end of the day today or tomorrow, but also I would like to remind you that FLACOS will be hosting their annual conference this year. The date for this year is October 19th and 20th. We really hope you all can attend. And if you have any questions, concerns, or anything like that, you can email me at smocas, M-O-C-A-S, @flacos.com. And I also will send out John, Terry, and John Wood's contact information as well. So if you have any questions about the webinar, you can contact them directly. We hope you all have a great day, and we look forward to seeing you this fall. Thank you.
Thanks, everyone.
Thanks.